I hope that today will be a fruitful day for everyone, and that we will take home some nuggets of inspiration and nuggets of wisdom on how to manage our women living with HIV, and offer them options for building their own family. But just because they have HIV doesn't mean that they cannot have a family of their own. If they want children, it is their right. No, it is their human right to have their own family. So the HIV diagnosis does not define them. An HIV diagnosis does not prevent them from having their own children, their own family, and finding the love of their lives. We just want to manage the risks of transmission to other people, especially when they are in a zero, what do you call this, zero discordant relationship, meaning their partners are HIV negative, they are HIV positive, and we also want to prevent their unborn children from getting HIV as well. Okay, so the objectives of this lecture is to discuss the principles of HIV transmission and management, particularly among women living with HIV, and to emphasize HIV screening, counseling, and testing during pregnancy to identify the available resources in the management of HIV/AIDS and pregnancy. I'm always very excited when talking about HIV because there's so much that we can do and so much love we can share. No? Sabi nga ng mga adolescent dito sa Cebu, share love, not the virus. And I am happy that we have empowered youth and adolescents nowadays who can already verbalize about spreading HIV knowledge and reducing stigma and discrimination against people living with HIV. So we will see in the statistics that HIV among adolescents is actually increasing. So we have to look at the data that we have. You know, sometimes we feel na it's so tedious to collect data enough to submit to EB or to the Epidemiology Bureau. But actually, there's a reason for this because we can use it in HIV advocacy campaigns like this. So I just want to let everyone know that we do have this HIV handbook, and this is where I based most of the slides in this presentation. So this is the most updated slides that I have currently. But looking at the Philippines now, we still have high IV drug use, particularly here in Cebu. No, it's the IV drug use that's problematic. 75% of all PLHIVs in Cebu are due to injection drug use. So that's I think a peculiarity in our areas because most cases of HIV for the rest of the Philippines is due to sexual transmission. We still see a lot of gender-based violence, especially during the COVID pandemic when people were not allowed to go out because of transmission of COVID. And then we also see an increase in teenage pregnancy because our adolescents are mostly sexually active nowadays and they don't really get access to family planning to prevent pregnancies. And at least I can say here in our hospital, more than 90% of mothers who deliver their babies are not married. So parang hindi na uso ang marriage ngayon, no? Ang wedding marriage. So they get children, they have their children even without the blessing of marriage. So that's fine, no? Because fathers can acknowledge their children nowadays. And you see still new cases of HIV and AIDS-related deaths. You have the late diagnosis when people opt in for testing when they have symptoms already. So we hope that we can catch HIV early, so early detection, so that we can still intervene with anti-retroviral drugs, and people can continue to live normal productive lives. So let's talk about Nancy. Nancy, I know we're not supposed to play favorites, but I do have a favorite patient. Let's call her Nancy. She ran away from an abusive home environment at 16 years old and finding shelter at a bar restaurant while working there as a waitress. After a few months, she was coached by the bar manager that she can earn higher if she would entertain the customers. So sabi, pwede siyang mag-table or tatabi muna sa customers and then encourage them to order drinks. So yun. So that's what her situation was, and she was 16 years old at that time. I think there are a lot of girls out there who have the same story as Nancy, and this is one of the reasons. This is not a direct cause of HIV, but this is one of the reasons that may lead to adverse childhood experiences that we have to prevent. Primary prevention of HIV infection for the key populations has to start in adolescence, because if you look at our data, more than 30% of new cases are among the 15 to 24-year-old age bracket. So adolescents, nagsisimula pa lang sila magregla, nagkaka-HIV na sila. So on average, the initiation to sex and drug use is between 14 and 19 years old. So it's important that HIV treatment hubs and primary HIV care centers have an advocacy campaign and participate in HIV awareness forums. Whether it's face-to-face or virtually, we can do this. Everybody has to be informed what HIV is and how this can be prevented. So I'm based or compared to the time that I first came to Cebu in 2013, I am happy that at least among the healthcare workers, there's already a reduction of stigma and discrimination, that it's okay, it's not a big deal if we admit HIV patients. So I hope that this is the same in your areas, in your treatment hubs and primary care centers. So I had to look this up, no? Matagal-tagal na akong hindi nagtitingin ng HIV kasi puro COVID na lang ang kaharap ko. But apparently there are changes in the way that the data is reported. And this is the data reported for February 2022. And in that month, no, we had 1,054 cases, new cases of HIV. And that would boil to an average case of 33 per day. And you see that there are still more males than females. And if you look at this red area, where red bar, 50% of the new cases are between the age 15 and 49. So why is this important? This is the age of people who are in their childbearing age or the reproductive age. And this is a golden opportunity for us to prevent mother-to-child transmission. And currently, we have 57,401 people alive on ART, and hope that we do not have loss to follow up. And most of these new cases are transmitted via sexual contact. And among the specific population, there were 7 HIV-positive pregnant women. So I would agree that since HIV counseling and testing is the gateway to HIV treatment care and support, it is important that pregnant women should be counseled and screened for HIV. No? So it's important that this is one opportunity for us to get like a catchment of HIV cases, because we have to know their HIV status before we can provide interventions. And special populations also include the overseas Filipino workers, those engaging in transactional sex, and the youth of 15 to 24 years old. And 70% of the mode of transmission is still through sexual contact. No, male-to-male sex, 70%, 21% sex with both males and females. And these HIV-positive males, when they have sex with females, these females can get pregnant. And that is why we have to talk about prevention of mother-to-child transmission. And luckily, among the children less than 10 years old and adolescents 10 to 19 years old, there was only one child diagnosed with HIV, reported through mother-to-child transmission. And the age of the reported case was 2 years old. We want to catch them during pregnancy so that we can provide intervention. Even if they weren't given anti-retroviral drugs during pregnancy, it would still be a good idea to test during labor and delivery, because we will be able to provide the infant, the newborn, with the anti-retroviral drug prophylaxis. So the DOH program of prevention of mother-to-child transmission of HIV was originated in 2009 pa. But this is still a program that we implement nowadays. So there are 4 prongs to the prevention of mother-to-child transmission. The first prong is that we prevent HIV among women of childbearing age. Kaya nga 15 to 24, they have to know about HIV, what it is, and how it is transmitted so that we know how it can be prevented. So we want women of childbearing age not to get HIV. However, if the woman of childbearing age does get HIV, no, if hindi natin nagawa yung prong number 1, there's always prong number 2. Prong number 2 tries to prevent those who are already living with HIV from having unintended pregnancies. So again, no, sa Paul kanina, we want them to plan their pregnancies. We want them to know when, how many children they want, and to make sure that their body, their psyche, their emotions are all prepared to welcoming this new child into this world. So one of the tenets would be the undetectable equals untransmissible. So to prevent transmission of HIV to another person, we want the viral load to be undetectable. And how do we do that? We make sure that those on with HIV are linked to care so that they are on anti-retroviral drugs and their viral loads can be undetectable. So before you get pregnant, it would be best to make sure that your viral load is undetectable so that if your partner is negative, when you have unprotected penetrative sexual intercourse, your partner will not get infected and the baby the unborn baby will not get infected as well. Okay, so there are interventions. If the patient gets pregnant, the woman living with HIV gets pregnant, then there are also prong 3 interventions to preventing mother-to-child transmission. Okay, during delivery, during labor and during pregnancy, during labor and delivery, and postpartum with infant feeding options. Okay, so that's prong number 3. Prong number 4 is providing treatment, care, and support to women living with HIV, their children, and their families. It is a known fact that there is still stigma, no, and there is still discrimination out there among people living with HIV. And it is our duty to make sure that they are empowered enough to call for help when they need it and to provide help that we can assist these patients to claiming their own rights and to getting the support that they need. Okay, so let's talk about prong 1. Prevent women of childbearing age from getting infected with HIV. So how do we do this? We look back on the modes of transmission. The first would be unprotected penetrative sexual intercourse with an infected individual. The second would be transfusion of infected blood through sharing of needles during injection drug use. And number 3, from an infected mother to her unborn child. As healthcare workers, we should not be afraid of HIV because it's difficult to get HIV unless you are having sexual intercourse with a patient or you are injecting yourself with their infected blood. So again, now we have to know the modes of transmission so that we can educate the patients, we can educate the community on how women of childbearing age can primarily prevent getting infected with HIV. And if you are in the community, you can share the methods of HIV prevention, especially among the youth and adolescents. It's as easy as A, B, C, D, E. A, abstinence. Wait for your one true love. And sana no get married before getting pregnant. And then B, be faithful. Be mutually faithful. Both the male and the female partner should be mutually faithful. Hindi pwedeng yung woman lang faithful sa man, tas si man faithful sa lahat ng women kung kanino siya nakikipagtalik. So C would be check your status, get tested and know your HIV status. If you're HIV positive, it's not the end of the world. You can use correct and consistent condom use to prevent HIV transmission to your partner. And then D, don't do drugs. Idagdag na rin natin, don't drink alcohol and don't smoke, because these are vices that can reduce your immune system or weaken your immune system. And then E, educate yourself and others for early detection. So di ba ang dali lang, A, B, C, D, E. In 1 minute, done ka na with informing the patient of methods of HIV prevention. And then these are pictures on before pandemic, and I hope that we can resume this again. Before pandemic, we used to go around the barangays, organizing 30 or so youth, talking about HIV and how to prevent HIV among the youth. And soon enough, sila na mismo ang nagto-talk about HIV prevention. And this also includes sexually transmitted infection prevention. So beautiful. They are taught how to regard sex as something sacred and something that they can give as a gift to their spouse on their wedding day. Yan. So let's go back to Nancy. Unfortunately, she was working at the bar as a waitress na entertaining guests, but she was coached by the bar manager that you can get more if you have, you entertain them elsewhere. So that para magkaroon siya ng lakas ng loob, binigyan siya ng something na injected, pampalakas loob. Unfortunately, that was drug use and they were sharing needles, and she had unprotected sexual intercourse with multiple partners. And this went on for an indefinite time period. Fortunately, she was rescued from the bar by an NGO, and when she was tested HIV positive. Okay. So the point of the case of Nancy is that if there were adolescent health programs that would have addressed adverse childhood experiences, they could have helped prevent child sex trafficking, because her case was a case of child sex trafficking. And adverse childhood experiences, or ACEs, are potentially traumatic events that occur in childhood. And for example, those experiencing violence, abuse, or neglect, and witnessing violence in the home or community. So this is something that is common among the patients that I have seen and managed. And there are NGOs that address this, but I hope that we can incorporate in our care that discussion on gender-based violence and adverse childhood experiences. So if there are hang-ups, we'll be able to manage them as well. Okay. So prong 2, let's go to prong 2 of the PMTCT of HIV. For those women with HIV, prevent unintended pregnancies through effective and acceptable forms of family planning. Okay. So I incorporate the principle of dual protection, because these are patients living with HIV. You have to protect them from HIV transmission through consistent and correct condom use, but still, on the other hand, prevent unintended pregnancies by using long-acting contraception. Examples of these would be your intrauterine device, or the IUD, this one, which is inserted into the uterus. And the other one is a subdermal implant, which is introduced just below the skin, under the arm. Okay, so why do we have to have both? Because we don't want them to keep forgetting taking their oral contraceptive pills on top of their anti-retroviral drugs. When you have long-acting contraceptives, they can forget about the contraceptive and know that they are not gonna get pregnant. But on the other hand, they still need to continue using condoms because this will prevent transmission of HIV. So contraceptives or contraception is the best protection obtained by choosing the sexual activities that do not allow semen, fluid from the vagina, or blood to enter the mouth, vagina, or anus of the partner, and correct and consistent use of condoms during every sexual act. And of course, going back to the ABCDE, what we want them to reduce the number of partners. If they are sex workers, it would be best if we can offer an alternative profession or livelihood. But if not, then at least we can provide them services to ensure that they are still protected against HIV. So going back to Nancy, Nancy was offered different forms of contraception and opted for the subdermal implant and correct and consistent condom use since she was dating and was sexually active. She hopes that he is the one. So one partner siya, no? She can tell her partner one day about her HIV status. This is very difficult because it's important and it's difficult to disclose to your partner, to your loved one, about your HIV status because of the risk na hindi ka ma-accept. Baka hindi ka kayang i-accept ng other person. So it's a risk that you have to take. Depende na yan kung gaano mo siya ka-love. Because if it's true love, then you will be able to accept the person, warts, pimples, and all. But we also have to support the patient on disclosure of their HIV status, ensuring that there is no that she's protected from gender-based violence. So let's talk about prong number 3. For the pregnant woman living with HIV, prevent mother-to-child transmission of HIV infection. There are 3 main points in time where we can do this. It's during pregnancy, we initiate antiretroviral drug or therapy at least 4 weeks before the woman delivers, as early as 14 weeks age of gestation. And for safe labor and delivery, you have different options. You may opt for cesarean section or you may allow vaginal delivery as long as some prerequisites are complied with. And you also have safer infant feeding during postpartum period. Infant feeding options should be discussed with the patient so that they ensure either exclusive breastfeeding or exclusive replacement feeding. So looking at the sources that we have, the POGS has this clinical practice recommendation on the prevention of mother-to-child transmission of HIV. However, we also have this newer edition of POGS and PIDSOC, a guidance for clinicians on prevention of mother-to-child transmission of infection, which discusses the cascade of PMT-CT services from antenatal testing, anti-retroviral therapy, safe labor and delivery techniques, safe for infant feeding, early infant diagnosis, and the final diagnosis for HIV-exposed infants through linkage of both mother and child to appropriate care and treatment. So going back to Nancy, luckily, Nancy's relationship with her partner lasted more than 1 year, and that was enough for them to decide that they wanted to settle down and they wanted to get pregnant already. So I met Nancy when she consulted for removal of the subdermal implant and that she had plans already of getting pregnant. So we had viral load determination. The partner was also tested, and with ARV adherence, her viral load was undetectable. So she was ready to get pregnant. Emotionally, psychologically, physically, she was ready to get pregnant. So luckily, Nancy already knew that she had HIV. But for several patients, they don't know their status. So providers of obstetric care should inform the patient that HIV screening tests will be performed as part of the recommended routine antenatal package of tests of infections, like your hepatitis, your syphilis, your rubella, the pap smear, and the urine culture for UTI. So include na meron siyang panel to test for infections during pregnancy. So HIV is included. However, our key message to convince patients to get tested is that the fact that you are pregnant, your pregnancy, it's an evidence of unprotected penetrative sexual intercourse, which is a mode of transmission of HIV. So the fact that you had sex and you are now pregnant, that is already a risk of transmission of HIV. And therefore, it's best to get you tested so that you know your status. So we have to do away with any judgment, any form of discrimination na, mukha ka kasing pokpok, kaya kailangan ka i-test. No. You have to just ensure them that it's part of prenatal checkup, it's part of the routine test for infections, and that because you had sex, that is also a mode of transmission of HIV. It is best for you to get tested and know your status. And then you let the HIV counselors do their job. So it should be part of the assessment in relation to her pregnancy. So part of the routine interview, prenatal checkup, plus you have the standard counseling about HIV, because HIV counseling and testing is the one test that should be coupled with pre-test counseling and post-test counseling. It's strictly confidential, and we have the opt-out approach, meaning you offer it. However, if they don't consent to the test, then they may opt out. Okay. When we administer antiretroviral drugs or therapy, we start triple antiretroviral drugs as soon as diagnosed and continue for life. This is test and treat, and we treat all. For pregnant women, we want them to start antiretroviral drugs at least 4 weeks before delivery. Based on a Canadian study, it was known that with antiretroviral drugs initiation, at least 4 weeks, the viral load was suppressed to undetectable levels, or at least less than 1,000 cells, so that there is less chance for the mother to transmit to her unborn child. So again, once you test positive for HIV, you start antiretroviral drugs and you continue for life. So yan ang forever, no? Forever sa HIV, you have your antiretroviral therapy. So the PMTCT program, you want to simplify the requirements, test them. If they test positive, start them on antiretroviral drugs. The child extended protection against mother-to-child transmission, because the undetectable equals untransmissible. And for partners, it also provides protection, benefit against sexual transmission in serodiscordant couples. So marami talagang benefits to get the woman tested for HIV. Even if she herself does not have high-risk factors for HIV transmission, she doesn't know about her partner. Usually that is the story that we have. The woman does not have risk factors, but unfortunately the man has. No? So earlier treatment for women's health and avoiding risk of stopping and starting triple antiretroviral drugs, especially in settings of high fertility. Our message is, once you start antiretroviral drugs, it is taken for life. For life, parang radio lang. So when we manage delivery, an elective cesarean delivery is scheduled at 38 weeks age of gestation. An emergency C is done for those in labor and with ruptured membranes less than 4 hours unless delivery is imminent. I'm sure some of you have experienced na dadating yung patient, crowning na, no? Isang iri na lang lalabas na si baby. So ganun, if that is the condition, then proceed with vaginal delivery. But if everything is planned out, it is best to have elective cesarean delivery scheduled at 38 weeks age of gestation. So vaginal delivery may be done when the risk of maternal to child transmission is low. For those who have antiretroviral treatment, at least 4 weeks, and those with HIV viral load less than 1,000 copies per ml, we usually test this at 34 to 36 weeks age of gestation. Viral load determination for pregnant women at 34 to 36 weeks age of gestation, so that we know whether we will allow vaginal delivery or schedule the patient for elective cesarean section. However, those with ruptured membranes, the time elapsed should be less than 4 hours to delivery. Okay? And we are promoters of essential intrapartum newborn care. So we still apply this to PLHIVs. We thoroughly dry the infant. We do skin-to-skin bonding, but we only do latching if the mother has decided on exclusive breastfeeding. Unfortunately, we do not do delayed clamping of umbilical cord because there might be transfusion of infected blood from the mother to the newborn child. So that's essential intrapartum newborn care. And as far as infant feeding is concerned, the most that I will say is that we do not encourage mixed feeding. The patient and her partner should decide whether they will be doing exclusive breastfeeding or exclusive AFAS replacement feeding. So AFAS should be acceptable, feasible, affordable, sustainable, and safe. Okay, and this is the statement of our Society of PIDSOG that HIV tested should be offered to pregnant women during antenatal care. Anti-retroviral therapy should be recommended to all pregnant women living with HIV to reduce the risk of perinatal transmission of HIV and optimize the health of the mother. And cesarean section is recommended to women living with HIV with documented viral load of 1,000 copies per ml or more with unknown viral load. So cesarean section is the first line of treatment. And breastfeeding is not recommended for women living with HIV because there are options of alternative modes of infant feeding. But I will leave this as the patient's choice, whether to exclusively breastfeed or exclusively replacement feeding, but not mixed feeding. An essential and postpartum newborn care protocol is modified for HIV-exposed infants: immediate cord clamping, immediate skin-to-skin contact without latching, and immediate bathing and drying. So prong 4 is providing treatment care and support to women living with HIV, their children, and their families. So we also have to protect our healthcare workers. Now, standard precaution, post-exposure prophylaxis, and hospital infection control. So even before there was COVID, nakabihis na kaming ganito. And then unfortunately, now we realized that you don't really need this kind of setup because all you need to do is review the modes of transmission of HIV. We don't have sex with the patients, and hopefully we don't get needle sticks or wounds intraoperatively. So these are some of the ways that we can support women living with HIV through immunization, healthy lifestyle, STI and cancer screening. So usually on their birthdays, I ask our PLHIVs to come over for free pap smear as my birthday gift to them. So we also have to look at opportunistic infections, support groups, livelihood skills training, advocacy to reduce stigma and discrimination, and HIV awareness campaigns. So looking at the WHO framework for women-centered approach, gender equality, and human rights, you see that women living with HIV would benefit from violence against women services for safe disclosure because many of our patients are afraid to disclose to their partners kasi baka daw mabugbog sila. So we want to prevent violence against women and children. And also family planning, because although they have a right, a human right, to build their own families, they have to plan it out well. And then antenatal care, if they do get pregnant, we should be able to provide prevention of mother-to-child transmission. And also safe abortion services in case they lose their pregnancy. We don't want them experiencing complications of abortion. And also, of course, because HIV is a sexually transmitted infection, we also want STI services because there was an increase among those with PrEP. There is an increase of other sexually transmitted infections. Walang HIV pero maraming ibang sexually transmitted infections like gonorrhea and chlamydia, which can also destroy the reproductive career of the woman living with HIV. And of course, sexual health, counseling, and support. So when you look at healthy sexuality across the life course, you want to provide adolescent-friendly health services. Looking at the case of Nancy, if we were able to provide adolescent health care and prevent the adverse childhood experiences, she wouldn't be in that vulnerable situation. And for those who test HIV positive, we should be able to provide anti-retroviral therapy initiated as soon as the patient is linked to care. And violence by an intimate partner or sexual assault, we should be able to provide immediate support, if not directly, refer them to those who can provide these services. And we want to prevent discrimination and stigma reduction. And these are all of the health interventions that we can provide for our women living with HIV. Okay, so voluntary HIV disclosure, children of school age, if they are HIV positive, they should already be told the status of by their parents or caregivers. And correct and consistent use of condoms, and hormonal contraceptives are also acceptable. The long-acting contraceptives will again include your intrauterine device or your subdermal implants. Okay, but we have to make sure that they don't have pelvic infections. So I will end with this. This is a person, a Facebook friend. No, he has been living with HIV all his life because he got HIV from his parents. But fortunately for him, he met the love of his life, was HIV negative, and remained HIV negative all throughout her 3 pregnancies. So his statement was, having a negative family can be the most positive thing in your life. So HIV should not prevent you from having that family, those children that you want to have in your life. And HIV should not prevent you from living a productive and normal life. So HIV stigma will end with me. Again, anti-retroviral drugs are for life. My forever is HIV. And we can help them, support them to have that wonderful life that they dream of. And everybody, whether you have HIV or not, the things that you want in life are the same. You want respect, you want love, you want support. Thank you very much.